My name is Marcus, in charge of medical education for Smith & Nephew Asia Pacific, supported by Varun Upal, marketing manager. We are pleased to support virtual exchanges like this wherever possible. Let us know where you're from, please. Janice, please start the first poll. Over the next hour, our speaker panel will share their own experience and techniques on advanced meniscus tears. This will be an interactive session, so please ask questions and provide comments through the Q&A box. I would like to thank our faculty and chairperson of today's webinar, Dr. Dimsha Pardiwala from India, Dr. Bancha from Thailand, and live out of the ACC Lab Singapore, Dr. Dave Lee. I will now hand over to Dr. Dimsha Pardiwala. I thank you very much for joining us today. Dimsha, your stage.
Thank you, Marcus. So we've got a really interesting program today on horizontal cleavage tears. And we've known that radial tears, usual vertical longitudinal tears have been repaired for many, many years. But horizontal cleavage tears, the interest has really grown in the last few years. So this entire webinar is dedicated for this. And we're going to have first an introduction on horizontal cleavage tears, which I will take. We'll then have a cadaveric demo by Dave Lee in the lab, and then we'll have some live surgical cases that Dr. Bancha will show us. So let's first start with just understanding how many of you have repaired a horizontal cleavage tear of the meniscus in the past. Usually you're going to find that some have and some have not. So how many of you have actually repaired such a tear? Okay, so keep that in mind when we get on to the last poll question. Great. Okay. And Janice, can you give us the answer to that? Great. So as you can see, about a few more than 58% have actually repaired a horizontal cleavage tear of the meniscus, which is a great thing, because I think now you'll see how things have advanced. And for those who have not, this would be a good opportunity to see how we can repair these tears. So I'm going to take the first lecture, which is about 15 minutes, to give you an overview on horizontal cleavage tears and what we've been doing up to now. What do we know about horizontal cleavage tears? We know that these are common types of tears, and in fact, 25% of all tear types are horizontal cleavage tears. And if we actually consider patients above the age of 40 years, then you're going to find that 36% of all tears in patients are horizontal cleavage tears. So these are a large number of tears. These are typically associated with degeneration and osteoarthritis. And unlike traumatic tears, which are classically either the vertical longitudinal tears, the bucket handle tears, and the radial tears, these really would be classified as degenerative tears. And classically, degenerative tears have been considered as tears that we do not repair. Now, these tears don't necessarily always correlate with symptoms. Often we'll find patients such as this with a very minor horizontal cleavage tear. And when this boy presented to me, he had severe amount of pain, a lot of effusion, and we gave him some non-operative treatment. And over 4 months, when the tear had extended to this, he then became pain-free. So sometimes radiology does not necessarily correlate with symptoms in these degenerative horizontal cleavage tears. And therefore comes, when do you really operate on these? And this we'll see in the next few slides. Why are these tears so important? We know that these tears, when you've got them, the tibiofemoral contact mechanics will change. So as you land up with the tear, the contact areas will start decreasing. So this is an intact patient. This is the patient with a horizontal cleavage tear. This is someone that you repair where the contact pressures are similar to that after an intact. But you can see that if you do an inferior leaf resection or a superior leaf resection, which was the traditional sort of technique for these horizontal cleavage tears, then the contact area starts decreasing. And with the contact area decreasing, the peak pressures start increasing. So we do know that if you were to treat these non-operatively, or if you were to treat these with a leaf resection, then these patients are typically going to land up with early osteoarthritis. Interesting study showed that these tears will often propagate with flexion. Something that we always thought, yeah, horizontal cleavage tears may not really extend with time. But a really good paper showed that if you start flexing your knee beyond 90 degrees, then these tears will deform and these tears will propagate with time. And therefore, if we do get a significant tear that's symptomatic, I think that instead of waiting too long and landing up with a larger complex tear, it might be worthwhile to repair them early, especially if all the other indications, including age, fit into the picture. Because if you don't, this tear will extend, this tear will then lead to meniscus extrusion and then increased condyle damage and osteoarthritis. How have we treated these in the past? So we've treated it typically with either non-operative treatment or partial leaf resection. And this is a great study that showed us that actually partial leaf resection increases contact pressures by 75%. So in a normal patient, these are the contact pressures. If you have an untreated tear, these increase. But if you actually do a leaf resection, then the contact pressures increase by almost 75%. Whereas if you were to repair them, then contact pressures come back almost back to normalcy. And that's the theory behind repairing these tears. It makes sense to at least get the biomechanics back into order. Now, when we first started these tear repairs about 12 years ago, techniques were a little different. I'm going to go through the different techniques that we've used over the years for these patients. So this is the technique that we used 12 years ago. This is a 41-year-old male. He's a recreational distance runner, and he's had progressive medial compartment pain of 6 months duration. And then he's presented with recent onset locking and mechanical symptoms. He's got normal alignment and no arthritis. And you can see that this is the classical tear there. He's got a horizontal cleavage tear there. He's got a small little cyst out here. That cyst is a multiloculated cyst. And when you see this in the coronals, you'll see that this is the large horizontal cleavage tear. And this is the cyst there at the back. Now, typically at that point of time, we didn't have all of these fancy instruments. So we repaired these with fast fix. So the first generation fast fix and then the fast fix 360 subsequently. You can see this is a patient with the flap tear there. Most of our initial patients always had these mechanical symptoms. So it was basically a complex sort of meniscus tear, a flap with a horizontal, and we treat the flap by resection. So get the flap out and then repair the horizontal. Now, before you want to do a horizontal tear repair, you want to make sure that you've really improved on the biology and you've also taken out the cyst. So you then put your shaver, go across through the horse, going across the horizontal cleavage. You can see all of the cyst material and the mucinous material coming out through the cyst. So you go across, get the cyst out, decompress the cyst. And once you've done that, again, use your shaver there in between. Try and get to the peripheral zone 1 area because that area has vascularity. That's the area that's likely to heal before you suture it. So put your shaver blade through the horizontal cleavage, get to the periphery, pressure that really well, and then go ahead with your repair. Now, if you were would look like, you'd have this superior leaf and this inferior leaf. You'd have this horizontal cleavage going right up to zone 1, and 2 of landing up with a recurrent cyst. So what we started doing about 10 years back is using the fast fix, first on the superior leaf, then on the undersurface, and taking these sutures, which basically compress the 2 leaves. When you're doing this, you want to use your probe to make sure that you don't overcompress it because you've got this going into the peripheral capsule. So this is truly not a circumferential compression stitch, but this will close down both the leaves. And this is the only real technique we had then in 2009 and 2010 when we started off with these repairs. So you take one fast fix and cut it off, and then you take the second one, and typically we do this with either 2 or 3 fast fix. So again, how do you do it? You take your fast fix through the superior leaf, then through the inferior leaf, and then tie it down. And then using your RF, you could just balance the meniscus well. And this is the sort of picture you get at the end. Your horizontal cleavage has been shut down, and you basically stabilized both the leaves. And our prime purpose for this was to ensure that no further propagation took place, and you didn't land up with a recurrent perimeniscal cyst. However, we know that when we take these sort of stitches that go through the capsule, you're going to get some amount of deformation of the tear, whether it's a longitudinal tear or whether it's a horizontal tear. And therefore, when we got the next generation of instruments in about 2012 and 13, we started using circumferential compression stitches. So this is a 16-year-old male. He plays football. He presents to us with a 6-month with pain since the last few months, and he has a locked knee since the last 1 month. He's had no significant injury, and he's had progressive pain then with that persistently locked knee. And we can see on the MRI that he's got a discoid lateral meniscus, which is locked. His ACL is normal. So that's the discoid there that we can see. We can see that he has a horizontal cleavage component there. Again, in the SAG views, you can see that he's got a significant horizontal cleavage component there. He's also got a peripheral tear. And so when we started doing these procedures first with the instruments that came out, this was the way that we did them. So that's his ACL. His ACL is normal. That's the locked bucket handle sort of tear from that discoid. So we're just trying to put it into place and try and get how much we need to resect. The central portion will be resected. So we put our duckbill biters in and get out an adequate amount of the central portion. And once that's done, we put the shaver in and reach the peripheral portion. So we've taken out all the central portion. We've now reached the peripheral portion, and you can see that that's our horizontal cleavage tear in there. Now, you certainly don't want to leave this horizontal cleavage component with in this discoid. And I know that I will repair the peripheral part, but before I do that, I'd like to take certain compression stitches in. And the instrument that we first had was this particular type of scorpion. And this instrument, I think, was a great instrument. We started off, but a lot of difficulties with this instrument, primarily because this was not meant for this sort of procedure. You could take these sutures which went around, but often you had to take it in 2 parts because it couldn't take the full depth of the meniscus. And once you tied these, you would then need to push the knot peripherally and then cut this off. And so typically we would take about 2, 3, or 4 of these sutures. And you can see that you need to be very careful, and sometimes you can't take both leaves. You have to take 1 leaf at a time. So it was a bit of a hassle. The second thing, the needle that comes out, you need to always visualize the needle because this needle can easily break. So you need to be a little careful with that needle. And this way you could take sutures, which were then simple sutures around the meniscus, and get your compression sort of stitched there and close that horizontal cleavage. And then finally, of course, that peripheral part would be sutured with a fast fix. But these instruments, although they managed to get us a requisite healed lateral meniscus horizontal cleavage tear repair, came with their problems. We got a circumferential compression stitch, but we had a lot of intra problems with these, primarily because with this generation of instruments, the needle came out. The needle which came out sometimes landed up on the cartilage. It was a little difficult to get both leaves of the meniscus And sometimes when you need to twist and turn this instrument so that the needle doesn't go into cartilage, we found that that needle could break. So we had our share of intra-instrument related issues with these needles. Moreover, often to do this procedure with a meniscus like this, you had to take just one leaf at a time, and we also had some needle breakages. So this made it technically a challenging procedure, which was, I think, our biggest concern while we were doing these. And therefore, when we finally got the first pass mini about 2 or 3 years ago, we started using these, and this remains today our sort of technique of choice for these horizontal cleavage tears. So this is the present technique that we use. This is a 46-year-old distance runner. He has a medial meniscus complex tear, so he's got a flap or a small tear there. He's got a horizontal cleavage there, and he's got a cyst here. Again, well seen on the coronal images. And this is the sort of technique that we've now used in the last 2 to 3 years. So first, the arthroscopy. You want to first see exactly where the tear is. And as I mentioned earlier, most of our patients are complex tears in younger patients. We don't want to do it in patients with significant osteoarthritis. We want to preferably do it in the slightly younger patients who are going to be active. I think these are the real indications for horizontal cleavage tear repair. So the first step is resecting zone 3. This zone is not going to heal. Zone 3 comes out. You then use your shaver or your duck bill and prepare zone 2. So you take out any of the loose tags of meniscus that you would find. You then define how much of a remnant of the meniscus do you have. And you can see that you've got a significant meniscus remnant there with that horizontal cleavage tear right there. And you'll also note that there's some amount of mucoid degeneration out here. So I'm just going to go ahead and shave that too. So now you've got this horizontal cleavage tear. Step number 1 becomes the preparation. And I think preparation is really critical for these tears. So you need to go to the periphery. You need to go to zone 1 and with the rasp first freshen that. I also then use the cannulae from the meniscus stitcher set and make 3 or 4 puncture holes. So trephination of the periphery. So you're making these small trephinations in the periphery. And by doing that, you're going to increase your vascularity. You're going to increase a little bit of a bleeding response there peripherally, so that when you close it down, there's a blood clot that comes in there. Finally, you use your small shaver blade, get into the meniscus, and start shaving the periphery. So you've got all of the loose degenerate tags and all of the mucoid degeneration out of the meniscus. And once you've done that, you've got your healthy flap above and your healthy leaf below. And now I'll start with my repair. So for the repair, I typically would use, the first one, I use a right curved suture. Passer. Now when you're doing this, you need to, there's a little bit of a technique here. So you make sure that you've got your both instrument. So you've got the superior part and the inferior part. So you've got both the leaves that you've got within the bite. This bite is a large bite, so it goes right to the periphery, to zone 0, zone 1. And then you need to slide it out. That's your first pass mini. In one shot, you've managed to get your knot pusher. You try and make sure that your suture goes on the periphery near the capsular part and is not sitting on the meniscal part. I then use a straight first pass mini, and you saw how I introduced it from the notch area and then slid it into the area there. Take the bite, again slide out. This instrument is a little large. It's not going to go in directly here. You need to go into the notch and then slide it. Once you've done that, make sure that your bite is going right to the periphery, right to the capsule, and then again, you need to tie it down. So that's your second suture. Once that's done, I'm going to cut that down too. And finally, I'm going to check whether I require a third one. So this part's open, I'm going to require a third suture there. So that's the first pass mini again. Open it, make sure that you've got both jaws of the instrument completely open. The only place you can open it is here. Introduce it so that you've got both leaves of the horizontal cleavage tear. It's sometimes difficult to see the needle come out, but because this is such a nice, robust needle, this needle will never break. And that's your third circumferential suture out there. And then again, you tie this down. Once you've tied this down with simple sliding sutures, you cut it off. And once you've cut it off, you've got your horizontal cleavage tear repair there with 3 circumferential compression sutures. So that's the end of the procedure there. You've got a nice, well-compressed tear. So that was the tear. And instead of leaving those leaves open, which could either propagate or form a perimeniscal cyst, we've closed it down, and that ends the procedure. Quite nice and simple. Now, over the years, we've seen that the clinical success rates of horizontal cleavage worthwhile to repair these in indicated symptomatic patients. However, even with the first pass mini, which is our present instrument that we're using, getting these circumferential sutures is sometimes not so easy. So you can see that this is the lateral meniscus there. If you don't have the space for this, of course, you could do a pie crusting to help you. But even then, it is a bit of a technical challenge to get this instrument in, make sure that the edges of the instrument don't scuff your cartilage above and below. And you need to, again, use that technique where you get into the meniscus at the most appropriate position and then slide it with its open jaws to the position that you want. Now, this is relatively a difficult sort of technique. And I can understand now why an instrument like the NovoStitch Pro had to come in. Because although you could use this for your horizontal cleavage tear repairs, it is a bit of a challenge, which could be a simpler sort of technique, then certainly it would be more successful. And I think that's why we've now got this instrument. This has just been released in India, I think a week back, but it's available in the rest of Asia. And this webinar will now show us how exactly we can use this simple instrument, which has an easy access, which is maneuverable inside the joint, and in which the needle gets protected within the instrument itself. And with this, you can take some circumferential compression stitches for not just horizontal tears, but you could also take it for radial tears, and you could also do a root repair with this. And this makes it really interesting that you've got an instrument now that's relatively simple and safe to use and makes this tear repair more reproducible and therefore easier for many more surgeons to use. And with this, I'm going to now pass it on to Dr. Dave Lee, who's going to show us how exactly the NovoStitch Pro needs to be used and show this. Over to you, Dave. Thank you.
Hi, good afternoon, everyone. I'm Dave. I'm from Singapore. Thank you, Ding Shaw. Thank you, Smith and Nephew, for the invitation to be involved in this webinar. I'm honored to be with my two good friends, Dinshaw and Bancha, both who I've learned a lot over these years. Outstanding surgeons, and there's a lot of pressure having to do this demo with them moderating. So NovoStitch is an exciting device launched by Smith and Nephew, and it fills an important void in the meniscal repair portfolio. So I followed this device when it was first developed by Centerix, a company. Sorry, I have to go backwards. Oh, okay. Company on the west coast of the US 5 to 6 years ago, and as I was interested, like what Dinshaw said, this is a device that can place a stitch perpendicular to the tear, which few devices can do, and it's especially useful in horizontal cleavage tears. One of the last frontiers of meniscal repair. We're going to, it's also useful in radial tears. And 2 years ago, Smith and Nephew bought over this company, and it's improved the manufacturing process, and it's now released in Asia in 2020. So I'll show this device. So you can see that it's fairly ergonomical. It has a button to launch the lower jaw. I don't know if you can see it, but the button here. And so it can be used with a single hand, and pressing this button will release the lower jaw. And so this is a meniscus model, medial meniscus, lateral meniscus. We will not be able to simulate a horizontal tear here, but I made a line for the radial tear. So as you go into a joint, and you can go into a joint as pressing the trigger, and it enters, and then once you're under the condyle, you can then release it. And at this point, you can bring the lower jaw in, and then you can slide under the meniscus, and this is all fairly low profile. You will see a line here, and this is where the suture will emerge. And so one of the things you can do is to just place a grip on the meniscus, give it a gentle tug, and this will ensure that you are getting hold of both leaves of the horizontal tear, and then you've pressed the trigger to fire. And you can see, I'm not sure if you can see the needle, but you can see the needle emerging. And from industry data, it comes out about 5 millimeters from the tip of the device. And this is when you pull back, and then you have your suture. And so if you're putting a hay bale suture, this is all that's required, and then you just emerge, and then you just release. And then this is when you will need to tie knot. So for me, I just do a simple knot in the same direction, okay? And then you dress the knot up. And I'm given this knot pusher cutter device that comes with this, and you can use it to then tighten it, and you can then basically use it to throw a couple of half hitches. This is in the opposite direction, and try not to make your knot too bulky. Okay, try not to make your knot too bulky. Okay, and so this will be like what you have seen in the video by Dinshaw, a horizontal one of what they call a hay bale stitch. And so you load, and then the same knot pusher can be used as a cutter. Okay, so that's the first, just on this model, how you would put a horizontal cleavage suture, a suture to repair the horizontal cleavage tear. And so I'm going to go ahead and, based on this line, simulating a lateral meniscus radial tear. So in the same way, you enter the joint with the trigger half press, enters, and after you navigate the condyle, then you can then bring the jaw up. You will press the gray trigger to launch the lower jaw, and you can see it sliding. And then again, you would then choose a position just on one side of the radial tear, and you will fire the novosuture. You can see the needle emerging again. And then without emerging from the joint, you will then choose a second spot, which is equidistant from where the tear is, and again deploy the stitch, and then you can come out. Okay, and so what this does, it creates a repair across the tear site. And again, you just have to tie your knots just outside the knee. And so we'll be demonstrating this in the cadaver, and you can slide it into the knee joint. I've just used this cutter for the first time today. I normally use one of the other cutters, the standard knot pusher. And so I'm also figuring out what's the best way to hold it, but it's pretty friendly to use. Oops. Okay. So anyway, you get the idea. Okay, so you cut. And so again, bringing the suture out. This is it. So you can use any cutting device that